Hello, everyone. I wanted to give a brief exposure to a tool from Tomlin and Borghetto in their proposed research pyramid for occupational therapy practice in a 2011 issue of the American Journal of Occupational Therapy. I'm a huge fan of it, and I think just giving some exposure to you guys here will help contextualize why we would even go about looking at literature from other fields and why we would place value on disciplines like occupational science that tend to appeal to qualitative methodologies a lot, both in their work in the social sciences and in the health sciences, and why it would really be important to classify this evidence differently and to think about what it means to critically consume narratives from the literature as we find it. The Tomlin and Borghetto pyramid is an alternative to this model, which you likely have been exposed to in your OT education. Sorry, I'm gonna back into the frame here. So you have likely been exposed to this in your OT education or in broader discourse about evidence-based practice and what that means in a healthcare context. And that's really where this is mostly discussed when it comes to coming up with claims that you can verify or falsify through formally published literature as it relates to human health. And the push for evidence-based practice in medicine came as a paradigm shift, a little bit of a disorienting dilemma, where previous schools of thought on medicine put a high degree of emphasis on expert opinion and more informally gathered information. And that many of the questions that physical medicine is asking, especially in relation to pharmaceutical testing, is how really tightly controlled physical systems operate within the body. And they're looking at how you can standardize care across a population and kind of use these hypothesis testing to minimize risk and minimize liability over time, and particularly with a focus on the physical systems in the human body. So with physical systems in the human body in relation to human biology, there's many parts of our physiology that have retained stability over evolutionary time and across a population set. So things like muscle tissue, or I don't know, what's another example? Maybe the circadian rhythm, performance, certain parts of our biology tend to be somewhat consistent across the sample set of humans or within a species. And so you can test hypotheses around physiology using discrete variable tests. Like, for example, you can use observation and testing of hypotheses where you're isolating variables and eliminating context noise to determine whether or not there are causal relationships between certain factors in human physiology with a high degree of liability. I've always contextualized that muscle tissue is definitely one of those things that you can ask questions and get reliable results utilizing a progression from case observations all the way up to randomized controlled trials, systemic reviews, and meta-analyses. So I included here a link that sort of describes this model of hierarchical evidence and a video that goes over it. It's likely something that you're familiar with. And it puts on a pedestal these large scale research studies, often with millions of dollars, that are brought in to facilitate these broad sample populations. And just with anything in hierarchy, we tend to dismiss anything that comes below that. And there can be this sense that in relation to a specific phenomena, if you don't have a certain type of study on a specific phenomena, that you don't have evidence for or against that conclusion, and that no matter how well done a study is on a specific scale, if it falls lower on the pyramid, then it doesn't have accurate conclusions about humanity and isn't worth factoring into our understanding of a specific phenomena. Over time, there's been a lot of critiques of this model in relation to understanding the functioning of human beings. Even in the biological context, it is a really functioning model for testing pharmaceuticals in particular, and it's really meant to test how you can generalize interventions across a full sample set of humans, and it's where we that appeal to normative statistical distributions and standardized protocols. for implementing recommendations. And it creates this culture of a one size fits all stamp of certain choices in relation to a patient population. There's been a lot of critiques of this model of evidence-based practice throughout the OT literature and certainly in the OS literature. I just wanted to direct you below to that. I was really impressed with chapter 3 of Occupation and Practice in Context, which is a really great sample of Gail Whiteford's critiques on this model of evidence-based practice. And it's really consistent. I've had critiques of this model because with occupational therapy, we're often not working with a standard or normalized population. Often people with disabilities don't exist within large sample sizes, and there tends to be a lot of variety between how folks are living and the type of outcomes that we're looking for in a patient population. And often to get results that are needed, we really have to customize our intervention to the individual. And it's also helpful to know some of the qualitative aspects when it comes to meaningful and purposeful activity. We're always interacting with a phenomena that can't be really placed on the evidence-based pyramid or removed from context easily. And I think that occupational therapy and occupational science poor fit with this model of evidence-based practice contributes to many of the challenges that we've had in adapting and developing a science base and an evidence base within our field that sort of can build traction in comparison to the other physiologically based sciences. OT works with physiology, but it's physiology plus. We are working with how people move, how they perform, and how their physiology interacts with what they want to do in the context of their environment, in the context of the time that they inhabit, and their personal goals and aspirations as an occupational being. And from that, we often need to use different methodologies to test those questions. And we really do need to take what our clients say about their lives seriously, and how they feel about what they're doing actually plays a significant and meaningful weight on the type of interventions that end up being successful. And often, if we try to implement a one size fits all broad swath intervention, it can actually make the functional performance worse rather than figuring out how to adapt and customize it. So I really loved getting Gail Whiteford's thoughts on this. So if you can get a chance to somehow peek at this text, I highly recommend it. And I wanted to link to you, if you do have an AOTA membership, you can link directly here to this article from Tomlin and Borghetto. And if you don't have an AJOT membership, you actually can access a copy of this article through ResearchGate by searching for this article through Google Scholar in the approach that we used in the lesson above. And I'm going to include here that seeing the critiques that were coming up in the OT literature and understanding the practice realities that OT practitioners are working in, Tomlin and Borghetto designed a modified evidence pyramid that really created some parity and some equity in valuing quality research that happens from a variety of different contexts and different scales in terms of adding value for clinical reasoning and context. And instead of putting just one pyramid that only looked at sort of physiological medicine, he included qualitative as having its own face, outcome-based research having its own face, and experimental research having its own face, with a foundation in descriptive studies of phenomena. And what this allows is this placement that we can put well-done literature for a variety of different research questions, because really, instead of evaluating the quality of research based on the type of the design, we really need to evaluate the quality of a research effort based on the question that it's responding to, the methodology in relation to what was sought out by the researchers, and how intrinsically valid it was within their questions and the case population at hand. And we really need to also leave it up to the clinicians and the contextual factors in figuring out what's useful in an intervention-based context. So really putting all types of evidence on the table when it comes to understanding a really inclusive picture of a phenomena and empowering both the client and the clinician and making accurate decisions based on contexts that are often rapidly changing. So I want to encourage you guys to get exposed to this research pyramid and to, as we're progressing through the literature, understand that every type of study has its place in understanding how occupational phenomena have developed, how they progress, and how we can intervene therapeutically. In future parts of the modules in this course, we'll look at how there's different types of clinical reasoning in occupational therapy, and each part of those has a level of research that is connected to that. And here you can see that qualitative research has its own pyramid within this, that there's actually different ways of assessing rigor within qualitative work, and that there are more meaningful research designs in relation to occupational therapy than the traditional systemic research pyramid. So know that you, as an occupational therapy practitioner, can start contextualizing research using this pyramid and not just the standard systemic research. Opening your mind to utilizing a pyramid like this and considering some of the critiques from occupational science and occupational therapy, for me, has helped correct some of the confusions in explaining what occupational therapy does and just how we're science-based. Often, it's not philosophically consistent to answer many of the questions meaningful to OT practice using randomized controlled trials. So we get caught in this rat race of, for example, trying to explain standardized sensory interventions, trying to pursue randomized control trials when on the ground we know that folks with autism or folks with dementia often have inverse reactions to sensory stimuli, and not all people experience sensory factors that are disabling to their occupational performance in the same way, and that in order to get effective functional and occupational outcomes, we often have to customize the interventions to the populations we're working with rather than standardize them across the population. And this shows that we can't really test some of these experimental questions. It's not that we can't test them, it's just that randomized controlled trials aren't always the right experimental design for that case. And often when we're looking to shift qualitative outcomes for a population, we're not always looking to do the same thing across the population. Sometimes it's helpful to get a small sample of folks that all share the same experiences and get an adequate understanding utilizing some qualitative methodologies. So I really love this pyramid, and so I just encourage you to look up this article and get exposed to it. And as you start engaging with the literature, you can start to think about how you can classify articles and assess them as related to your practice using this pyramid instead of the standard one from a traditional medical model. Thank you.